This is Tom Lee, editor-in-chief for NEJM Catalyst, and today we're going to be talking with Jeremy Caldwell, the chief physician at Sanford Health, about innovation in rural health and how it might spread to the rest of the healthcare system. I reached out to Jeremy after hearing some thoughtful comments about two different models for innovation in healthcare. One driven by where there is money, and one driven by where there are needs. The fact is, a lot of innovations are targeting Medicare Advantage because there's so much money flowing through for the care of those patients. And the goal is to figure out how can value be created to make that care even better. The other model that was brought up was from health plans addressing poorer populations like Medicaid, but also rural health. And in this latter category of innovation, there are critical needs that just can't be met by traditional models of care. And rural settings seem to provide just that kind of laboratory where innovations can be tested and then spread to the rest of healthcare. So after that discussion, I thought we should check in with Jeremy, who is a key leader in one of the most innovative rural systems in the country. Jeremy, can you start by telling the audience a bit about Sanford Health today?
Sure. So Sanford Health is a rural population system, if you will, in the upper Midwest. We're headquartered out of Sioux Falls, South Dakota. Our footprint overall covers a landmass of roughly 250,000 square miles. For scale, that's about the size of the state of Texas. And in that population, we take care of, North Dakotans, South Dakotans, Minnesotans, some Nebraskans, some folks from Iowa as well. And as we're doing all of that, one of the things I think that is abundantly clear is there is a lot of land and geography there. We exist in some of the places that people would call primary care deserts. We definitely exist in places that people would call mental health deserts. And as you look at subspecialty care, the average metropolitan area has somewhere around 300 to 320 subspecialists per 100,000 people, and we're a lot closer to 30 subspecialists per 100,000 people. And so all of those things mix together to allow us, our 4 major medical centers, our 40 smaller medical centers, and all of our clinics to really spend time in that footprint trying to figure out how to do things both as traditionally as we can when it needs to be, and also as differently as we can when we need to reach out to people in a different way.
Now, you hinted at some of them, but why don't you tick off some of the big problems that you're trying to solve, the problems that we all have, frankly, but that are even more intense for you?
So I think a couple of the ways I would mention that is first and foremost, I think there's been lots of coverage in the media about the loss of obstetrics care, particularly in rural areas. If you want to look up an area called Bemidji, Minnesota, Bemidji is a small town up there in the northern lakes area of Minnesota, north of the Twin Cities. What you will find there is 4 or 5 of the local hospitals around Bemidji have lost their ability to provide OB care in their last 5 to 10 years. With the known retirement of at least a third of our primary care physicians in our footprint over the next 10 years, we recognized that we had to do things a little differently. And so our OB group in Bemidji has started reaching out and providing some of that ongoing specialty care with the patients in ways that makes more sense to them. A grant called the Our Moms Grant, Rural Maternal and Obstetric Medicine, was able to get us a little bit of a kickstart so that we could say, we're going to actually provide non-stress tests, so the belts around mom's belly, in places that hadn't previously been provided. We can do that in emergency rooms where there might be an APP covering, and we can even do it at home from time to time to make sure that that mom who may or may not have good internet access, who may or may not have reliable transportation to what could be 120 miles back and one way to their obstetrician, has that ability. And with that information, with that ability to then download that stress test the next time they're within Wi-Fi, be it at a local coffee shop or a grocery store, that information is keeping those moms up to date on American College of Gynecology screening recommendations for a pregnancy, and they're doing it all without making that mom take half a day off of work every other week or possibly even every week to make sure they can drive from wherever they live to Bemidji, Minnesota and back.
Let's go a little bit more into that challenge of distance. You can't ask someone to drive 6 hours just to get their blood pressure checked. And the truth is, I shouldn't be asking them to drive 45 minutes in Boston to do that either. So, can you give us some other examples about how you are redesigning care to account for distance so that maybe the rest of us can make care better by making it easier too?
Sure. I think one of our other examples is uh, in the Dakotas right now, there is one pediatric pulmonologist. So if you happen to be a cystic fibrosis sufferer or suffer from some other malady as a child, there is only one doc that you can go to. He happens to live in Sioux Falls, South Dakota, which is lucky for me. That's where my family lives. But if you're in Dickinson, North Dakota, you're 6 or 7 hours from that specialty. And so the ability to hook up our clinic in Dickinson to our pediatric pulmonologist in Sioux Falls and have him be able to do a heart and lung exam with the child, with the parent, and with one of the providers from Dickinson in the room allows all of them to synthesize that information at the same time. And so it really gives them the opportunity to say, we're going to be able to manage your care and keep it as close to home as possible. Like you mentioned, the hypertension recheck, I think any of those things that we can do via virtual visits have been, extremely rewarding. Mental health care, which is a desert for almost every county in the Dakotas, save three, really truly does get helped by the fact that at this point, even after the pandemic, roughly 20% of our mental health visits are still executed on virtual care or via a virtual platform, which means those folks who are having difficulty can be reached out to even in times and even in difficulties where they would normally have to drive 2 or 3 or 4 hours just to find their physician. And they don't have to do things like take work off. They don't have to modify their kids' schedule if their kids are in, practices or school or otherwise. And we have some really great stories about the ability to gain that mental health care. One of the areas we've jumped into as well is what I would now call low tech. It may be different for the folks on this audience, but considering my kids won't use text messaging at this point, we have to call that old school. And so using text messages and some pre-prepared text messages to check in with our patients, whether they came out of the hospital for heart failure, mental illness, or COPD, we can send them a text that basically just gives them a 1 to 9 scale and says, how are you doing today? And I'm happy to say that we already have a couple of catches in that mental health follow-up after the ER, where we've recently caught a mom who was having a 1 out of 10 day. And was able to get her connected that morning with professional help and assistance. And what we didn't realize was that after she had sent her 3 kids to school that day, she had written her suicide note. And we were able to catch her, get her back on the right track, get her back into professional help, and truly do the job that we were supposed to do in using that text message that said she was having a 1 out of 10 day to go back and really deliver the care we were supposed to and that we would be expected to as those who deliver the best care that we possibly can in those rural areas.
Your examples are great. And the one about the pulmonary pediatrician being so far from so many patients reminds me of one of my friends who has 4 children who says that she still has PTSD from getting all of her children into their snowsuits and bringing them to the pediatrician's office just so one of them could have a visit. So it's really a wonderful thing that you're doing by finding some other ways of doing business. But that leads to the next item I wanted to bring up, which is, there is only one pediatric pulmonologist. There are actually shortages for all kinds of personnel, especially physicians, but other types of personnel as well. Everyone in healthcare is having that challenge of not having enough clinicians to meet needs, and it's getting worse as medicine gets more complex. So how are you thinking about trying to do more with less?
So I think one of the areas that we do this with some regularity here in Sanford is specialists like endocrinology. There are lots of appointments where the right answer may not actually be that you need to drive to your endocrinologist to talk over your blood sugars or your thyroid conditions. One of those folks in our Fargo market actually has about 20% of his schedule as virtual, in any given week. The part that's amazing is when it gets to the winter in Fargo, North Dakota, which you can imagine is not particularly pleasant, his schedule goes up to 40, sometimes higher than 40% virtual, so he can see the folks that would have trouble traveling. And the other part is the rest of his clinic team does the same thing. So if you're a diabetic educator and my friend puts you on a new medication, and you leave the office understanding what you're supposed to do with that new medication. But as many of us do, that when things aren't new anymore and the education kind of fades, he has his team ready to assist virtually to help them get ready with whatever their new medication is, to follow up with whatever questions they have afterwards. And so it's not just the doctors that get to have all the fun. We get to have virtual visits with our diabetic educators and with our other team members as well to make sure that they're helping out those patients even after they leave the clinic, or sometimes if they never had to visit at all.
Oh my gosh, when I called you to ask you to do this, I was thinking about distance, but I hadn't thought of the weather and cold and wind as being things that create even more pressure to allow patients to do things without having to leave their home. So I love your story there about diabetes. Well, let's go deeper with diabetes and get down to how do we learn how to give first-rate care and then deliver it. I think I'm a reasonably good primary care doctor, but the truth of the matter is I don't feel confident that I know how to start patients on treatment, train them on the monitors, and so on. So what's the answer to this that you're coming up with at Sanford? Do teams take over, or do you tell PCPs like me to get with it and learn more so I can do the new stuff?
Um, without telling you to get with it, Tom, which I would never do, I will tell you we use the team approach. It's absolutely important for us that we understand that while the initial instructions may come from your primary care doctor or may come from your specialist, we all recognize the fact that there's a voltage drop when you leave the clinic. You understood everything perfectly when your doctor was sitting right in front of you and you were having the conversation. It's a very different thing entirely if you're changing medications, if you're starting on a new medication. As we use the diabetes example, what if you're starting on a new injectable? All of those things are things that we, in each of our clinics, have somebody that's an expert, or we know who to call that's an expert, or we have a specialist down the hall or across the street who's an expert. And so our goal is really to say, whether you're across the street or whether you're across the state, we want to be able to connect you with those folks so that you can avail yourself of the entire healthcare team and absolutely get hooked into, I'm on a new medication, it's an injectable, I'm not quite sure how this pen thing works, and I want to talk to my diabetic educator, and we connect those folks directly to say, hey, this is the team you need, and this is the people you have available to you. So whether it's because of the weather, whether it's because of distance, or whether it's because of simply this isn't the day that it's going to work best for you to make that trip, we can connect you virtually if that's the best choice for you that day.
So how are your patients adjusting to new models? Some of my friends who work in disease management companies say that rural patients tend to be more independent, and that doesn't always help the effectiveness of their programs. Is that true? And if so, what can we learn from how you are adjusting?
Well, I think if you've ever seen the musical The Music Man, one of the songs in there is called the Iowa Stubborn. Um, and I think whether it's the Iowa Stubborn or whether it's simply your stoic Midwestern farmer, it is true that we probably don't come into the doctor's office as often as we should or as often as we could, and that can result in disparities of care. One of the things I like to tell people is you're never going to see a farmer coming in during harvest season. If you see a farmer coming in during harvest season, you can just assume they're horribly ill from something. And in those situations, it's important for us to recognize the fact that Our goal is to keep them out doing the things that they're doing, but also, and probably most importantly, keep them connected to the healthcare they need so that if the right answer for them is a virtual visit from their farm, if the right answer for them is a virtual visit from their farmhouse, we can make those things happen for them. And we can do everything we can to keep those stoic farmers and those other folks doing the job they need to do and connected to healthcare to make sure they're getting what they need from a healthcare standpoint as well.
Oh my gosh, I love that observation. And I'm wondering what the equivalent is for me in Boston. But let me wrap up now by just asking you if there were two or three key takeaways that you think physicians like me and others elsewhere in the country have to learn from rural health, what would they be?
I would say number one, whether you're across town or across the state, there are always good reasons for people to say, I want my primary care or I want my specialty care, but I don't necessarily want to make that trip today. So having a virtual option available is always a way to make people maintain that connection in a way that they previously haven't or they previously haven't ever availed themselves of. I think number two, innovative ways, no matter where you find them, whether they're in large cities or whether they're in small towns, help show us the way to continue to provide great care and continue to provide that, in our case, premier rural experience for our patients no matter what they have going on. And so whether it's obstetrics, whether it's endocrinology, whether it's pediatric pulmonary medicine, those are just a couple of the examples that we use here on a regular basis to talk about the ways to reach out to our patients on any given day in a way that makes sense for them.
Well, Jeremy, I have to say that one thing that ran through my mind as you were making your comments is that anyone who thinks that high value healthcare is just about saving money and reducing spending is wrong. And I hope that they read the transcript or listen to this podcast because you have described ways of improving effectiveness and improving efficiency as well, where efficiency takes into account not wasting people's time. I'm so glad that you're doing this work, and I know I'm always going to be learning valuable things by paying attention to what you do. And you can expect I will be asking you to come back and speak more and write more for NEJM Catalyst in our audience.
We here at Sanford Health would love to. Thank you very much for the time today and the opportunity to talk a little bit about our patients and our people.